Hello, and welcome to today's webinar discussing the pharmacist's role in closing infectious disease care gaps. I'd like to introduce our panel for today's discussion. We are pleased to welcome Dr. Mercedes Bernard, a family medicine provider from Comanche County Memorial Hospital in Lawton, Oklahoma. Also working with Comanche County Memorial Hospital is Richard McCormick, and he is one of Clearway Health's clinical pharmacists there in Oklahoma. We also have Brenda Shee, who is a clinical pharmacist with Clearway Health and works with Neighbor Health located in Boston. And lastly, we have Rachel Arnold, who's also one of our clinical pharmacists here at Clearway, and she works with the Brooklyn Hospital Center in New York. And I will be your moderator. I'm Danisha Lewis, Clinical Program Coordinator with Clearway Health. And our company was born out of Boston Medical Center, and we partner with hospitals and health systems to build or strengthen their own specialty pharmacy program. So today we'll speak specifically about two infectious diseases and the pharmacist's role in closing care gaps. The first disease we'll discuss is hepatitis C virus or HCV. So the World Health Organization has created HCV elimination targets with a goal of 2030. So a few of those targets are reducing new HCV infections by 90%, diagnosing 90% of the HCV infected population, reducing hepatitis C virus deaths by 65%, and treating 80% of eligible patients. So this graph is showing us the estimated new hepatitis C virus infections versus the annual US targets from 2017 to 2023. And as we can see here, the actual observed new hepatitis C infections exceeds the annual elimination targets. Now, this graph is depicting the rate of hepatitis C related deaths and annual US targets. So from 2017 to 2023, the target is being reduced every year. And as we can see, the actual observed deaths are lower than the targets that have been set by the World Health Organization. So we know that the goal of reducing HCV related deaths by 2030 is on track from what we just saw, but progress on lowering new infections has been slower. So, Dr. Bernard, from your experience, what factors are contributing to these mixed outcomes?
Yeah, this is a really good question, and something that I think we can, you know, where does the discrepancy lie? And I think the difference is really rooted in a combination of like the medical breakthroughs that we've had and public health hurdles and a lot of just evolving risk behaviors that have occurred. So why are the deaths falling? Well, overall, we have really highly effective treatments and we can cure hepatitis C, to over 95%. Which is fantastic. And that is, leading to fewer people progressing to those end-stage liver disease and death. We also have the expansion of early testing with improved linkage to care. Additionally, I think when we're thinking about why are the deaths falling, we had a large reservoir of older patients, our baby boomers traditionally with long-standing advanced disease. And those patients are either mostly cured or have unfortunately succumbed to death related to their progressive liver disease. So, I think that that's why we're seeing a trend with the rate of death. But why are the new infections declining at an even slower rate? Well, I think that that really involves a multitude of things, and we can't ignore that we are still pulling ourselves out of the 2020 COVID pandemic. We had a perfect storm at that time where we had large public health disruptions. Patients were not seeing their physicians, had fear of the healthcare system for fear of COVID, and we had reduced testing, prevention, routine health exams were not occurring, and then within that perfect storm, we also have the introduction of increased community transmission through people who inject drugs, and so because of that. we're not quite getting a lot of those harm reduction services when it comes to IV drug use. So that paired with continued stigma, lack of awareness, barriers to healthcare, um, that really has created this trend that that we're not meeting our mark. So overall, I think that the mixed outcomes really reflect it's twofold. We've had a lot of medical triumphs and treatment mortality reduction, but alongside we also have a persistent social, structural, and behavioral challenges that are related to Hep C prevention.
Thank you for sharing all of those factors that are, in fact, contributing to these mixed outcomes. So, microelimination, it focuses on breaking down the national HCV targets into smaller population-specific goals in order to help us kind of reach these targets. As we've seen, we're off track here. So this is a new area of focus, and pharmacists play an important role in this collaborative approach. So, Dr. Bernard, in your view, what are the most impactful ways pharmacists can contribute to microelimination efforts?
Wow. Here's where I can't speak highly enough about clinical pharmacists like our own Richard McCormick and Michelle Cody, who have personally assisted me, but not only just assisted me, but empowered me to feel like I could take on the hepatitis C population. I am family medicine trained and I trained in rural Oklahoma. But how I've always perceived hepatitis C, especially through my residency training, was that this was a disease process that could only be handled by a specialist who had a lot of knowledge about the medications that went into that. And um, that's not the case anymore. We should, as family physicians, in the primary care setting, feel empowered to take on these patients. And it makes it a lot easier when you have a pharmacist who can really make this impact by bridging the gap between when we've screened that patient and identified them to getting that patient to a sustained virologic response. So it really turns, those pharmacy encounters in between into opportunities to help identify those patients, to initiate the medications. And then in that process, they're really supporting the treatment and supporting the patient. They help me by figuring out the prior authorization process, which is tenfold more than I could ever imagine to do on my own. They counsel the patients on those medications. They monitor their adherence. They offer education. That it's really by having a clinical pharmacist to partner with. They are my lifeline to making sure that we are, meeting these targets of getting these patients treated to completion. And I could not do it without them.
Absolutely, absolutely. Well, thank you for that. We definitely appreciate the collaboration between pharmacy teams and pharmacists and our providers. It's definitely critical for our patients and our outcomes for the patients. So, linking patients to care after an HCV diagnosis is critical, as Dr. Bernard just shared. So, Rich, how is your clinic working to close care gaps and strengthen linkage to treatment?
No, we have taken we've taken a very open communication approach. We've got very open communication with the labs in order to get those lab results. Those patients that have been screened either in Dr. Bernard's office or even perhaps when they were in a hospital stay or come through the ER and being able to identify those patients with that open communication in a timely manner from the lab is critical. Once those patients get away, uh, it's really hard to get them back. Um, Secondly, is within Dr. Bernard's office, we set up a single point of contact. I've got a patient here who needs to be seen, and I know it's going to be taken care of. Uh, they are really great about working those patients in a very efficient. It's not a 3 month wait. It may be a week. It may be 10 days. It may be in 2 days, but they're really good at getting that in. That line of communication that I know I've got one person I can go to make that happen. And for follow-ups, absolutely crucial. That's a huge part. And then lastly is bringing the patient uh, into the communication line as well. Hey, this is what's going on. I'm going to do this for you. I'm going to get you that appointment. I'm going to navigate the insurance hurdles find out what your copay is, get you assistance, whether it's from the state or from the manufacturer, or a copay card, whatever that is. Um, then I'll arrange for the medication to be here, and I keep them in the loop the whole time. But those open lines of communication between the lab, the provider, and the patient, and bringing that all together so that everybody's on the same page, absolutely crucial. And I think has been a game changer at our site.
Thank you for sharing that. Communication is one of those points that you really brought up, and just having a coordinated plan of action for patients and linking them to care. So here, we really just wanted to illustrate for everyone our Hep C test to treat funnel. And so as we just heard from Dr. Bernard and Rich, what we start is really with that screening. So at the top of this funnel, you see that we have system-wide Hep C screening is what we're recommending. And it just depends on the model at the specific hospital or clinic, but that can come from the PCP, that can come from the ER provider, or any other provider. And once we actually get that system-wide screening in place, then all of those results can come to a centralized hub and a dashboard. So the clinical pharmacist can then review those results and triage those patients to the appropriate level of care. So that could be a GI specialist, that could be a PCP champion, that can be an ID specialist. So it's all depending on the actual model that's created that really takes care of the patient need at a specific hospital or clinic. And then once the patient is linked to the appropriate level of care, then we go to that specialty pharmacy team. So that's when we make sure that we're working on medication access for our patients, like Rich just described, and Dr. Bernard as well, and treatment monitoring. And then we are going to monitor and follow these patients all the way to cure and sustain virologic response. So in New York, HCV screening is required for all adults and for people with certain risk factors, yet gaps in care still remain. So, Rachel, how is your team helping to close those gaps and link patients to care, both at your clinic and even beyond in the community there?
Yes, so once we receive the screening results, we have a pharmacist follow up on all positive results, and we connect these patients to care within either our GI or ID clinics. Once the patient is seen by the provider and treatment is initiated, we then have a counseling session prior to the patient receiving the medication. We run our drug-drug interaction reports, we review the labs, and ensure the selected treatment is appropriate to initiate on our end, as well as counsel the patients on the selected treatment, such as the purpose, administration, and common adverse events of the medication. During the treatment, we follow up with the patients closely to ensure adherence and completion of the entire course of therapy. And then within our program, we have also identified opportunities to link patients to care beyond our clinical site. So we have reached out to local shelters who share mutual patients, and we share high-level information and educate staff as well as the residents so that we're able to bring more patients into care and be linked.
Thank you. And I just love that not only are we looking at the patients that are in our actual clinics, but we are looking beyond, because we know that this is something that affects patients beyond our clinics that we're actually able to see. So I love that you all are doing that there at the Brooklyn Hospital Center. So here we really wanted to include a visual workflow sample, just for the record. And this is really just showing a potential workflow for hepatitis C screenage, from screening to linkage to care. We wanted to include that here, and it really summarizes what's already been shared by our panelists. So direct acting antiviral therapy is highly effective in curing HCV. And so, Rich, what strategies are you using to reduce treatment attrition and support patients in completing therapy?
Well, one, the DAA therapy is utilized whenever possible. It's a fairly simplified treatment. It's once a day, pan-genotypical, fairly short duration. We can use these only for 8 to 12 weeks. This helps reduce the pill burden and also reduces complexity. We make it as easy and simple as possible. Uh, these regimens have been really, really incredible in being effective and being very accepted by these patients. As the others have touched on, a lot of it is patient education. Bringing them in and knowing I'm with you all the way. This is what you can expect. This is what you can expect from me. I'll be in touch with you, whether you want it or not, every 7 to 10 days to see how you're doing and reporting back if there's any concerns or any issues. But patient education and following up with them, very, very important, as well as emphasizing that they complete their treatment. But that regular check-in and monitoring, whether it's by in-person or phone, has really made a world of difference in preventing these drop-offs, and preventing future drug interactions when they go to the doctor or see other doctors and get a new prescription, just to make sure that they're not taking something to impede this treatment. It's been really great.
Thank you. Thank you. So making sure that we're educating our patients, they're informed about the process, and then really just walking with them and communicating with them along the way. So thank you for sharing that. So even after patients are linked to care, some barriers to successful treatment still remain. So Brenda, what challenges do you see, and how does your collaborative specialty pharmacy workflow help overcome them?
Great, thanks, Donisha. So definitely we see a lot of barriers to hepatitis C treatment even after patients are linked to care. But thankfully, our specialty team, we're very well equipped in overcoming these barriers, and we do a lot of problem solving for the patients just to make sure that these patients can get their medicine and continue on their therapy. So one of the barriers that we see is the high copays, which we've also mentioned earlier in the webinar about the prior authorizations and some of these copays that we see. Sometimes even after the PA, the prior auth is approved, the copay is still like $2,000. So our liaisons, they do a lot of investigative work to sign patients up for savings programs or connect them to other programs to get them the medicine. So we do a lot of problem solving there. Another barrier that we see is adherence. So Rich talked about this earlier. We have patients who are worried about the side effects, and our pharmacist does a lot of counseling to help alleviate those worries and keep them on track or help manage the side effects if they come about. And then finally, we help with the care coordination. So sometimes during the hepatitis C treatment, a lot of unexpected things happen. For example, I had a patient who was in a car crash and he just stopped therapy. So I intervened to help tell him what his next steps are and whether he could resume his treatment, stuff like that. Um, yeah, we have people go to the ER or perhaps they relapse, and our pharmacist is that point person who intervenes and helps guide them for their next steps.
Thank you. Thank you, Brenda. So again, just really making sure that we're communicating with those patients. That's just a theme
Yes.
that I'm hearing throughout: communication, education, and really walking along with them, especially since we have such effective therapies. It's critical for us to ensure that we are staying engaged with our patients to ensure that they get to the actual treatment and have that sustained viral load level. So we also just wanted to include another sample workflow, and this is actually the hepatitis C treatment workflow. And this is just included for your records if you wanted to take this model and try to implement it at your site. So now that we have discussed how pharmacists can close care gaps in hepatitis C, we'll discuss the pharmacist's role in addressing gaps in HIV care. So the National HIV/AIDS Strategy aims to end the HIV epidemic by 2030. And some of those targets are listed here. So one of them is to reduce new HIV infections by 75% by 2025, and then by 90% by 2030. Also, increase linkage to care by 95% by 2025, increase viral suppression to 95% in those who have an HIV diagnosis, and to increase PrEP coverage to 50% by 2025. So the tables here are showing that progress that we've made towards these 2025 National HIV and AIDS strategy goals. So our first chart is showing the 2025 goal versus the last data year, which was 2022, the actual linkage to care numbers, and also viral suppression. So as you can see, we're not quite at our targets for 2025 versus the last data that we have in 2022. And also for the new HIV infections, that number exceeded what the actual target was set to be in 2025. So since the 2017 baseline year, progress has been made toward those 2025 HIV targets, but acceleration is still needed. So Dr. Bernard, based on your practice, what factors are contributing to both the successes and the ongoing challenges?
Gosh, much like before, this is another balance in those successes and challenges, right? So we can, again, share joy in the fact that we have expanded HIV testing and rapid linkage to care for our patients who have been diagnosed with HIV. The increased access to antiretroviral therapy really helps people achieve that viral suppression, thereby reducing illness and transmission. The growth of PrEP for our pre-exposure prophylaxis programs, syringe support systems nationally, those are things that are really paving the way. But there's small growths within our personal healthcare system. Again, that collaboration with a clinical pharmacist to empower me as a family physician who, again, once thought that HIV was something that had to be treated by a specialist, and building my confidence in taking on HIV patients, developing those partnerships so that you can have direct line of communications. In Southwest Oklahoma, I can sometimes often feel like I live on an island when, greater specialists are an hour and a half up the road in major metropolitan areas. But I have, through my clinical pharmacist team, have developed relationships with Ryan White clinics and HIV clinics in Oklahoma City. And so that's been really effective in resource sharing. Now, what's going on with the challenges? I think what we're still facing is persistent stigma, discrimination and funding gaps, which create barriers to care, of course, with prevention, especially for these marginalized groups. Specific to my patient population here, when I bring up HIV screening for some of my patients, they think that that screening doesn't apply to them because they don't recognize, they think that that's only associated with high-risk behaviors. That doesn't identify with me. So there's a lot of that stigma that still exists. For our greater population, I would say that the socioeconomic challenges are probably our greatest hurdle. We have unstable housing, lack of stable health insurance access. All of that continues to hinder, the engagement in a treatment process program. So basically, what it breaks down to is accelerated progress is going to require breaking down structural and policy obstacles and then scaling up our evidence-based interventions and investing more in resources and educating primary care physicians to feel empowered that they can take on this patient population so long as they've got the team to support them.
Thank you, Dr. Bernard. And I really love how you're saying like having these collaborative team is helping the providers also feel empowered because you have the support from the pharmacist to address these challenges. And so we know that PrEP therapy plays a critical role in advancing HIV elimination. So, Rich, how are you linking patients to PrEP at your clinic specifically?
Well, for the most part, we have cloned our hepatitis C program. Direct connection with the lab gives us screening of a certain population of patients, those that have repeat STIs or multiple STIs. that would not normally think of, hey, I might need this, just as Dr. Bernard said, these patients sometimes will think that does not apply to me, but it very well can. Reaching out and identifying these patients, and whether it's reaching out to their primary care provider or over to Dr. Bernard's office if they don't have a primary care provider, to try to get that established link. That's been our primary source at this time. It's been fairly successful, but it's with that stigma that Dr. Bernard referred to. It's somewhat of an uphill battle, and the insurance payer roles that also comes into play. But it's it's been good. We've been able to take our experience with hepatitis C and apply that to this other disease state, and it's working out better than expected.
Thank you, Rich. And here we really wanted to, again, add a workflow so you all would have an example of our actual STI screening linkage to care sample here. And as Rich described, really looking at those patients that are testing positive for other STIs and ensuring that they are being screened for HIV. And if they're testing positive for HIV, we're linking them to proper HIV treatment. And if they're testing negative, then we're linking them to PrEP therapy. So this is an example of how that workflow could look in your particular clinic or hospital. So, Rachel, long-acting HIV treatment, your clinic, I'm sorry, has had great success with long-acting HIV therapy. So for both management and PrEP, and you all are achieving 100% viral load suppression. So can you just share with us how your interdisciplinary workflow has made this possible?
Yeah, so by rounding with the ID providers, we're able to engage with patients and participate fully in their care. We monitor their labs, their adherence, and tolerability to injections, and really have that face-to-face with patients so that they know when we're calling, they can trust us and have a conversation. Once we identify a good candidate for long-acting antiretrovirals, we track their injections to ensure they are receiving them timely. We have all prescriptions for these injections sent to our outpatient pharmacy, so we can ensure processing and resolve any insurance or financial barriers prior to their injection date. If we notice a patient is not scheduled and their dosing window is coming up, we will reach out to scheduling to ensure the patient is able to make it in for their injection, or recommend oral therapy if they will not be able to present within their window. Once the patient is confirmed for their appointment, we'll bring their injection to the clinic the evening prior to prevent any delay and ensure a smooth process for both the patient and the healthcare professional administering the medication.
Thank you, thank you. And again, thank you for, helping those patients at your particular site achieve that 100% viral load suppression. So long-acting HIV treatment has shown significant benefits for patient outcomes. And with the introduction of even a new long-acting PrEP option this year, Brenda, how is your team working to ensure patients and providers are informed about and connected to this preventative therapy?
Hi, so our team is working very closely with our HIV clinic and the HIV clinic providers to help make sure that they are informed and connected to the long-acting PrEP therapies. So some things that we've done is that we've helped the clinic generate a list of all the patients who are candidates for switching over to long-acting PrEP. We're also helping the clinic create a workflow so that once the long-acting PrEP medicines are available, we can switch patients over more easily. And then finally, we're monitoring the payer coverage. So once the PrEP injectables are or can be covered by insurance, then we'll notify the HIV clinic in a timely manner.
Thank you. And that's really important to really support, as Dr. Bernard listed, having that support from the clinical pharmacist team to make sure that our providers and nurses and everyone on that side, they're really supported and ready to, transition these patients to some of this PrEP therapy. And as Rachel listed, really having that coordinated team and that
Yes.
coordinated workflow is truly critical for our patients.
Yes. Close communication and
Yeah,
workflow.
absolutely, absolutely. Thank you. So now, I really would like for each person, we'll start with you, Dr. Bernard, to share a memorable patient experience that highlights the impact of the Clearway Health clinical programs.
Yeah, I rather than sharing a patient experience, I want to talk about just my own experience. I think that as a family medicine physician, so oftentimes you don't get a lot of big wins in medicine. A lot of times your time is spent watching the progression of a chronic illness become more chronic. And harmful to the patient over time. But being able, for example, to treat hepatitis C in our clinic and seeing a patient come in the door, getting them to a sustained suppression, and then seeing the renewed faith that they have and confidence that they have, and suddenly they want to take ownership of their own health. And I think previously that hepatitis C diagnosis where they had barriers to care and they couldn't seek treatment before in the past, and they had been carrying this disease process for a long time, having that metaphorical weight off of their back is now allowing them to, make healthier decisions moving forward. They're more empowered about their health, and that's really exciting as a primary care provider who sometimes just needs a good win every once in a while. So it's so rare in primary care medicine to actually get to cure a disease state. And so that's probably been the most impactful thing for me as somebody who has, dipped my toe in the water, in the metaphorical water, finally getting into these infectious disease treatments and feeling empowered about it.
Excellent, excellent. I love that. Rich, would you like to share a memorable experience?
I've got several memorable patients and experiences over the past couple of years. But I think more importantly is the overall replies that I get from multiple patients in that you've made it so easy. Been made so easy to take this medication that I've been dreading for 10 years or 15 years that I've been living with it because I heard it was so horrible. And you and the doctor's office has made it so easy to get this done and complete. That story I hear almost on a weekly basis. How easy it is to get in touch with the providers, how easy it is to get this medicine once we have it set up the way our program is designed. And I've just had, like Dr. Bernard said, you get those wins very seldomly you really feel the appreciation. And a lot of these patients who have also been marginalized and sometimes often just discarded as people really appreciate that attention and the recognition that they are a person and that you've taken the time to help treat them. It's more of an overarching than a specific patient. Very
Absolutely.
wonderful.
Thank you so much for sharing that. Brenda?
All right. Well, I feel like I'm still recovering from what Rich shared. But yes, I feel like every patient is memorable in their own way. I know that's like very cheesy to say, but everyone is memorable in their own way. Recently, I did have a patient where I'll share this example. He's an MMA fighter, and which is a big part of his life, like big hobby of his. And he was telling me how, like, since he's been diagnosed with hepatitis C, like he cannot fight anymore. He's banned because of the risk of the blood contact. Um, so that was one of his motivations for proceeding with the hepatitis C treatment. He did finish his treatment. We're waiting on his SVR, but it's just cases like these where it really reminds me just like how much of an impact that our provider team can make for the patients. So like hopefully once he is cured, he'll be able to go back to, being an MMA fighter and having this big part of his life just back for him. So very excited for him.
Wonderful. That's wonderful. Thank you for sharing that. And then Rachel, would you like to share?
Yeah, so like everyone has mentioned, there have been many memorable patients and experiences to be able to help patients linked to care. There is a recent patient I had a counseling session with to check in on how they were doing on their long-acting antiretroviral. When I have these counseling sessions, though, we go ahead, we review all of their labs, all of their medications, and he told me that he wasn't taking his statin. So, I kind of asked why. He just wasn't sure why he needed to. So I discussed with him the purpose of the medication. We reviewed the Reprieve trial and just kind of gave him a different perspective, maybe than the doctor was able to or somebody else. And the patient came in for his injection actually the following week. And afterwards, the provider came out and told me that the patient finally started taking the statin after one counseling session with me when he had been trying to convince him to take it for the past year or so. So that was just an impact that a pharmacist could make on just giving a different perspective to patients sometimes.
Thank you. Thank you. Thank you to each of you for sharing. Those were awesome. Just the general patient experience as well as those specific patient experiences that you shared. So I would like to thank each panelist for contributing to today's discussion about the pharmacist's role in closing infectious disease care gaps. We really appreciate each of you and just everything that you've shared with us on today. And then I'd also like to thank everyone that is attending today's webinar. We greatly appreciate your time. And if you have questions about the content in this webinar, or Clearway Health Specialty Pharmacy Services, please visit us at clearwayhealth.com.